Welcome, everyone. My name is Amanda Falk. I am a partner and chief clinical officer at the Dorm, New York City and Washington, D.C. Really excited to be here with David Rowe, who is the director of neuropsychology at United Assessment. United Assessment works with clinics across the country and is a grateful partner of the Dorm. David has a very impressive background in neuropsych research and testing. In addition to his work at United Assessment, he is the psychological testing supervisor at Andrus Children's Center and a faculty member at the William Allenson White Institute in the Child and Adolescent Psychotherapy Program. He teaches classes in child psychology, abnormal psychology, and psychobiology, and is an assessment supervisor at Columbia University and Mercy College in New York City. He is also currently researching the impact of oxytocin on the negative symptoms of schizophrenia at Silver Hill Hospital, where he is a consulting neuropsychologist. We are so excited to have David here today to talk about the benefits, limitations, and nuances of neuropsychological testing for the young adult population. Before we begin the presentation, I just want to address some housekeeping items. This will be a roughly 30 to 35 minute presentation. After the presentation, we love to engage in a more interactive discussion. So please put questions in either the chat or the Q&A throughout the presentation so that we can address those questions at the end. Following this presentation, you all will receive slides and a recording so that you can view it or share it with others as you wish. And with that, without further ado, I wish to welcome David Rowe, who is going to take this presentation from here.
Thanks, Amanda. I really appreciate it. It is absolutely a pleasure to be here with you and everyone. So we are going to be discussing what neuropsychological testing actually is and how to help clients and families make informed decisions following testing. Then we're going to go over a couple of assessment case studies, and at the end, we're going to have plenty of time for questions. So neuropsychological assessment is fairly esoteric. I'm sure that all listening providers have had, innumerable testing reports across their desks over the course of their careers with varying degrees of applicability, but hopefully not legibility. And there's not a lot of information about testing out there. So I'm hopeful this will be a dynamic experience to kind of ideally provide some clarity into the field. So first things first, disclosures. The following slides are solely for educational purposes. Absolutely no solicitation is being made to any attendant or viewer, and the opinions I express are in fact mine and not representative of those of United Assessment. So what is neuropsychological assessment? To understand neuropsychological assessment, I'd like to start with a thought experiment. So if someone were to ask you, what is the most important organ in your body, what might you say? Well, you might have a couple of thoughts. You might think your heart pumping your blood, your lungs oxygenating that blood, your skin keeping it all in, but chances are you'd land on the brain. It's a hallmark of what makes us uniquely human, which is especially interesting considering that thought, that suggestion came directly from it. That's right. The brain is the most important organ you have according to the brain. And it's not wrong. Objectively, it's the most complex part of the human body. It's been called the seat of intelligence, the interpreter of senses, the initiator of movement, and even the controller of behavior. And the brain can be subdivided into seemingly infinite components. It's often compared to a computer, but the reality of it is, the entirety of Silicon Valley wishes they could make a computer as powerful as the brain. There are no less than 86 billion something happened. Right, 1 second. So sorry. See, this is why I have to do one more time with feeling. I was about to tell you something so fascinating about how many connections there are in the brain. It's not just about the neurons, it's about the synaptic connections, which is here. There are no less than 100 trillion connections in the brain. For comparison, there's only about 100 billion stars in the Milky Way. So that's about 1,000 times more neural connections in one human brain than stars in the galaxy. So naturally, as humans, we try to partition the brain into meaningful areas so that we can make sense of it. And these attempts can vary pretty greatly in scope, ranging from broad, which is to say a matter of lobes, to hyper-reductionist, a matter of systems. And ultimately, as you can see from my colorful slide, the brain is a veritable paint by numbers. But to really truly understand the brain, we need to understand not just how it works, but what happens when it doesn't work and in what ways. So for our purposes, we're going to break it down into the simplest possible division, literally right down the middle, the left brain and the right brain. So research has suggested that the left brain is the logic center, focused on sequence and linearity and facts and reasoning, while the right brain is the creative center, the home of intuition, synthesis, rhythm, and imagination. And these two sides work in tandem to make us whole. But the two sides don't just float next to each other, they're connected by the corpus callosum, which is a large bundle of more than 200 million myelinated nerve fibers that connect the brain into two hemispheres, permitting communication between the right side and the left sides of the brain. But what happens when that connection is severed? To give you a true sense of how important brain functioning is, here's an anecdote. Often, as a last resort to treat epilepsy, a doctor might conduct a corpus callosotomy, which is an operation that transects the corpus callosum, interrupting the spread of seizures from hemisphere to hemisphere. They literally cut the brain in two. While that might provide some relief to epileptic patients, it also provides a window of insight into what can happen when one side of the brain stops talking to the other. And we call these subjects split brain patients for all of the obvious reasons. Now, it's important to know that because of contralateral or crossover connections, the left brain controls the right hand and the right brain controls the left hand. In split brain patients, if they're reading a book in their right hand, they can happily continue reading. But if they pass the book to their left hand, the left hand will put the book down, even if they've voiced a desire to read it. This is because the verbal information in the book from the left hand is sent to the right side of the brain, while the language center is on the left side of the brain. So in short, the left hand puts the book down because the right brain simply has no interest in reading it. Humans are apex predators, top of the food chain, the most advanced known organism, but only when things are working perfectly in unison. And to be clear, and to normalize the experience of patients everywhere, they so rarely are. And that's where we come in. Neuropsychology is a complement to neurology, where neurology often assesses structure, neuropsychology explores function, and more importantly, sometimes dysfunction. So the old axiom is that structure informs function, but one has to ask, does structure inform treatment, especially in the mental and behavioral health space? Awareness of functional deficits certainly does. And while the nature of neuropsychological assessment can be bidirectional, where data derived from an assessment can be mapped to physiological analogs in the brain, understanding functioning is essential to effectively treating patients. So what is the difference? Structure is what something looks like, what is impacted. A CT scan, an MRI, they can tell you if there's a lesion, a hematoma, a hydrocephalus, but it can't tell you how that affects someone's learning, their attention, and their memory. Neuropsychological assessment looks at function, which is what the brain does, and not just what, but how it's impacted. So the question is, what actually is neuropsychological assessment? And what would a presentation be with at least one definition slide? A neuropsychological assessment is a battery of tests that measure how a patient's brain is working, especially when it's disrupted by a brain injury or a psychological disorder. And it covers a wide range of mental functions. Neuropsychological assessment is more broadly, psychological assessment focuses on several domains: cognition, language, attention, learning, social, emotional, behavioral functioning, personality functioning, reasoning, visual spatial skills, motor speed, and thought process, to name a few, all with the intention of helping a client achieve success through insight. So as a neuropsychologist, I'm principally a statistician and a diagnostician, right? In a field where there's so much of the work is reliant on inferential and impressionistic information, which is to say, clinical judgment, neuropsychologists use a battery of valid, reliable psychometric tests to arrive at a diagnosis. But here's the important part. Collaboration is key. It's working tandem with the clinical team of providers. We're able to provide quantitative information to augment the qualitative nature of their work. Therapy is incredible and rewarding and creates real change. But whether dynamic or behavioral or insight or skill-based, collaborative or exploratory, it requires patience. And insight is often derived slowly over time, and skills take repetition to not just learn the skills, but to learn how and when to use them. And a major goal of neuropsychological testing is to derive clinically meaningful data to expedite that process without compromising the integrity of the therapeutic work. But how? And as much as I love phrases like data-driven and empirically based, let's get into the specifics. So neuropsychologists use 3 types of tests: objective, subjective, and projective, which I like to conceptualize as self-evident, self-reported, and self-revealed. So first we have objective tests, the self-evident. Objective tests are tests that have right or wrong answers. Through puzzles and patterns and acquired knowledge, it assesses attention and memory and processing. It can explicate verbal comprehension, perceptual reasoning, and even executive functioning, which is to say the higher level skills used to plan and organize, multitask and problem solve, make judgments, and maintain self-control. One prime example of an objective measure is the IQ test. IQ, operationalized as the capacity for intelligence, is an essential data point for understanding what an individual is capable of and what can or should be expected of them during the treatment process. And then next we have subjective tests, the self-reported. Subjective tests are tests in which a patient knows what information they're revealing about themselves. Excellent for assessing depression, anxiety, mania, obsessionality, compulsivity, disordered eating, suicidality, homicidality, and self-harm. One classic example of a subjective test is a social emotional behavioral questionnaire. A patient is asked to self-reflect and endorse their experience on a host of personal questions. And through this process, this kind of broad metric has the potential to explore, screen, identify, and assess all of these areas of potential psychopathology. So finally, we have projective tests, the self-revealed. Projective tests are tests in which a patient does not know what information they're disclosing about themselves. Through the use of open-ended, ambiguous, and immediate prompts, these tests are opportunities to form a window of insight into the patient's psyche, trends of thought, and internal process. The novelty and the unobvious nature of these tests reduces the chance for attempts at manipulation, as well as the basic ability to manipulate them. The classic example would be something like an inkblot test, which is when we respond to a stimulus based on instinct and impulse, the patient often projects their feelings and thoughts and preoccupations, as well as their sense of the world on that stimulus, which creates an opportunity to get a glimpse beneath even seasoned, well-oiled defense mechanisms. So one question I frequently get is how neuropsychologists make sense of something as ambiguous a response as an inkblot test, or how do we make sense of that information? And on first glance, mapping these kinds of responses to psychiatric symptomology might seem like comparing apples to oranges, but that's where norm referencing comes in. Norm references allow us to ensure that we're comparing apples to other apples, right? Through this process, we compare characteristics of the individual and of the individual's test results with the same characteristics in a comparable normative group. We can match patients to others, their age, their achievement level, or their similar clinical picture. In fact, even projective tests have been norm referenced on thousands of people from a wide range of demographics, symptoms, and severity. This way, we can determine the relative standing of a patient taking the test. Practically, this allows us to determine strengths and weaknesses relative to a patient's cohort. So for example, percentiles on a social emotional behavioral questionnaire, where looking at the size of a standard deviation a score is from average, can help us determine the differences between major depression and general teenage angst. We then take these scores and turn them into qualitative descriptors. Is someone average or high average or low average, superior or impaired? And ultimately, those norm references allow us to not just collect the data, but to compare it to other people's data. And we turn it into meaningful categorical information and make it digestible, which is where the report comes in. So once all the data is collected through the test administration, it's analyzed, synthesized, and interpreted, and then written up into a comprehensive report, which will document the patient's history, explicate the test results, summarize the diagnostic impressions, and provide gold standard recommendations based on the data derived. If that sounds time intensive, it's because it is. The test administration process can take anywhere from 5 to 10 hours or longer, depending on the patient, and the back-end work of analysis and report writing can take dozens of hours. So why do it? And when is the right time to refer a client for an assessment? Now, to be fair, Being a dyed-in-the-wool believer of the power of assessment, I am, or possibly biased, because I genuinely think that assessment can be helpful to anyone, anywhere, all the time. We live in the information age, and as insipid and as trite as it may sound, knowledge is power. Google and Amazon are valuable because of their data. Target can tell from their data mining algorithms that a person is pregnant before they know they're pregnant. Everyone has data on us except for us. And the difference is that the data derived from a neuropsychological assessment is used not to sell you targeted products, but to help you be your best self. Now, again, I don't think there's a single person who couldn't benefit from an unbiased inventory of their strengths and weaknesses. But that being said, there are ultimately a host of reasons to get evaluated or to refer for evaluation. But it really depends on when and for whom the utility of the results of the evaluation is going to be maximized. So while the patient is always the top priority, as in every segment of the mental health field, there are several stakeholders in serving the patient. And ideally, neuropsychological assessment has an impact on all of them, touching on an individual's micro, meso, and macro systems. So first, we have the individual themselves, the intrapersonal. Patients are often referred to assessment to help with diagnostic clarity, to help an individual understand their experience, give them a name for their experience, a community of people who understand so they feel less alone. It can assist in determining strengths and areas of development, learning more about themselves. It can be really helpful to maximize their strengths, minimize their weaknesses, and optimize their functioning. Helping a patient gain a better perspective and clearer insight can help facilitate transformation in their lives, giving them data to adjust their priorities, such as, for example, securing their commitment to treatment. Next, we have those around the client, the interpersonal. Assessment can help a family better understand the patient's experience, which allows them to better support their loved one. Within a family system, data can provide an opportunity for reflection on each individual's contribution to the dynamic. Another major aim of assessment is to assist the treatment team in honing their treatment framework. While assessment isn't a treatment in and of itself, it is a powerful treatment tool, and to evaluate all variables and to reduce, if not eliminate, the possibility that there's a confounding factor underlying that's perpetuating some of the difficulties that's gone unaddressed is a useful foundation for driving treatment through informed decision making. And finally, there's the systems that within which the client exists, the institutional. And many patients don't just need but deserve extra supports or services or accommodations, and due to their issues they're facing through no fault of their own, struggle with activities of daily living, let alone achieving success and advancement through development. So neuropsychological assessment report is key component in any application package to secure these kinds of supports and services and accommodations, whether they're societal or academic. On an institutional basis, assessment can help create, assessment doesn't create an unfair disadvantage, it helps to eliminate an unfair disadvantage. It's about leveling the playing field. So you refer for assessment, the testing is administered, the data is collected, the report is written. How do you use this information? What happens next? Well, it depends. Which sounds like I'm shirking the question, but this is not your kind of run-of-the-mill equivocation. It depends for a reason. While assessment reports are static, unyielding, immutable documents, assessment feedback should be dynamic, tailored to the party for whom they're intended to best meet their needs. I think it's the best way to demonstrate this and these nuances is through kind of contrasting cases. So without further ado, I'm going to introduce you to Jane and John. So Jane is a 19-year-old female who presents with a recent history of social isolation and academic disengagement, as well as escalations in depression and anxiety, and a maladaptive relationship with video games. Per her parents' report, she always performed well in school, but struggled with social emotional reciprocity and theory of mind. She had a good group of friends, but had a hard time making new friends because she had difficulty understanding how other people feel and how she makes other people feel. They thought that she was just an awkward kid. They assumed that the depression and the anxiety symptoms they were observing were in line with the normal ebbs and flow of teenage psyches, especially given her recent transition to college. They figured that she was just homesick. It wasn't until after she was academically dismissed after her first semester, and that she was unable to meaningfully re-engage in school or work for over a year, that her parents had a glimpse into the severity of her symptoms, and she first presented to treatment. Testing demonstrated exactly how severe those symptoms were, with anxiety and depression scales in the 98th and 99th percentiles, respectively. Resulting from the decompensation at school and her separation from her cohort, she developed profound and persistent mood and anxiety symptomology. Even more interestingly, on a subjective test of social responsiveness, Jane's score suggested significant difficulties with both social communication and interaction, as well as restricted interest and repetitive behavior. Ultimately, testing revealed that Jane met the criteria for autism spectrum disorder level 1, major depressive disorder, generalized anxiety disorder, and an other specified impulse control disorder related to her video game use. Jane had had a friend group all through her life, but having made these friends in elementary school, they just accepted her for who she was and stayed with her. Facilitated by attending a private school from kindergarten through 12th grade with the same cohort, her difficulties with social pragmatics flew under the radar. However, when she went to college, her difficulties were profound because she was faced for the first time with social demands that exceeded her innate capacities. She felt ostracized immediately and isolated, and she developed deep feelings of depression and anxiety, and she retreated into the world of video games. She demonstrated and endorsed classic symptoms of addiction as they related to video game use. She spent more time playing than she intended. She, was emotionally dysregulated when separated from them, and she would stay up all night disrupting her sleep schedule to play. However, what Jane's parents didn't see is that this use promoted her sense of self-belonging, her sense of sociability. These internet-based video game platforms provided a safe haven for non-judgmental interpersonal connection, right? And allowed her to practice avoidance while also forging a virtual community. Ultimately, testing revealed a young woman who had always struggled with a developmental disorder but had never been identified, who struggled to tolerate the increasing academic demands and social expectations of the college environment, who developed pronounced depression and anxiety as a result of that struggle, and who ultimately developed a maladaptive coping mechanism in the form of video game use. But Jane is the perfect example of a situation in which knowledge is power. Interpersonally, conducting a full feedback session with Jane was transformative for her in her treatment. The autism diagnosis put the pieces of a puzzle together for her and made sense of what, for a lifetime, she couldn't put her finger on. She had long felt that there was something inaccurate or unidentified in her clinical picture. And she reported having felt or even having known that she was different in some way from her friends, but she couldn't verbalize it. Following the feedback, she voiced feeling validated and that this conceptualization had helped make sense of her experience. She expressed a recommitment to treatment, a restored sense of hopefulness in the future. Interpersonally, Jane's family voiced a sense of relief, and her treatment team noted a renewed understanding of the meaning and the direction of their work moving forward, switching from cognitive to more behavioral work. Institutionally, Jane slowly returned to school, and once she rematriculated, she was offered emotional and behavioral supports in and outside the classroom to support her learning. John, on the other hand, is a very different case. John is a 23-year-old male presenting with a lifelong history of depression, as well as recent self-reported issues with inattention and memory impairment. Notably, John had an extensive treatment history. Beginning at age 10, he experienced episodic depression, for which he sought psychiatric and therapeutic interventions. His psychiatric history was remarkable for multiple hospitalizations for suicidal ideation and gestures, as well as severe, a bunch of residential treatments. And during these periods of depression, but preceding the intervention, John experienced immense emotional and behavioral inertia, and his life would just kind of grind to a halt. In the past, John has maintained his prescribed medication regimen, but only in treatment, would experience a full remission of his symptoms and then would return to life as usual, only to then self-discontinue his medication, triggering another cycle of depression and treatment. John presented for assessment during a protracted inpatient stay, notably following a suicide attempt, but then began behaving in kind of an erratic way while in treatment, voicing fears that the hospital staff was poisoning his drinks and requiring him to kind of hypervigilantly guard and replace his cups, among other kind of persecutory paranoias. Additionally, he began reporting somatic complaints related to his brain functioning, believing that the medications he had taken previously in life had caused irreparable brain damage. And he noted that he could no longer attend to or memorize any information, which further contributed to his low self-esteem and low self-concept and exacerbating his depression. Now, to assess for basic cognitive functionings, John was given an IQ test, a classic, the WACE, which he performed very well on. And while there was a relative weakness in memory compared to his overall ability, he still performed perfectly within the average range. Now, to supplement this test, John was given 2 tests of executive functioning, a subjective test and an objective test. Now, in the subjective test, we asked John, does your brain work? And he effectively said, no, I can't inhibit my impulses. I can't shift sets. I can't remember anything. I can't plan. I can't organize. But when we gave him an objective test and actually asked him to apply these faculties across the board, he performed really well. And this discrepancy is clinically meaningful in a number of ways. One, it demonstrates that John doesn't always have good insight into his true abilities. And two, it says something about his self-concept and self-narrative. In John's case, based on the aggregate results of the evaluation, he met the criteria for major depressive disorder with psychotic features manifesting as disorganized thinking, paranoid trends of thought, and both persecutory and somatic delusions, as well as generalized anxiety disorder. And John's case was particularly fascinating from a feedback perspective because it seems like the perfect case to help derive insight. One would think that this is kind of a golden opportunity to leverage the data to clearly show John the discrepancies between his expectations and his reality, which would ideally bridge the gap in understanding. And while the data derived is theoretically irrefutable, John wasn't ready to process it in a healthy and productive way, which is to say it wasn't the right time to deliver the feedback. He was suffering from anosognosia, which is a symptom of psychosis in which a patient's unaware of their own mental condition and unable to perceive it accurately. Delivering this kind of feedback at that point in time would have likely resulted in a therapeutic rupture and clinical retrogression. Instead, John most benefited from biochemical restabilization through psychopharmaceutical intervention and supportive validating therapy, until which time he was able to reorganize his thoughts and slowly derive insight. But once stabilized, assessment results were able to be titrated and delivered in a way that he could understand and use in treatment. On an interpersonal and institutional level, these results were far more immediately effective, resulting in an augmentation to his medication regimen and affording him medical leave from work. So, because Jane's experience, her openness, her readiness, and her receptivity, assessment results were used to move the needle in her self-awareness, bringing previously unknowable unknowns into consciousness and removing significant roadblocks to effective treatment. While John, the assessment results were equally as important, but we were able to see that he wasn't yet ready to digest them, at first at least. And but equipped with the results, his team was able to mobilize around him and adjust their approach and methodology until John was more stable and prepared to use the data to take the next steps in his treatment. So ultimately, neuropsychological assessment is both completely standardized and completely tailored. So psychometrically consistent, but individually personal. And it's genuinely and generally a wonderful tool in a therapeutic toolbox, at least according to the brain. So that's the general overview.
Thank you so much, David. This was wonderful. I know that many of us who are therapists watching this presentation, we so often, when we start working with a new client, receive, testing, and a lot of us will just go scroll down to the bottom and sort of look at the recommendations and not, truly be able to absorb everything that the testing has to offer. And I think this presentation was a wonderful introduction to all that testing can do and how it can help us to be better clinicians. I have seen a lot of different questions coming in through the Q&A, so I wanted to bring some of those to your attention. The first question that comes up, and something that I've often thought about as well, is can you speak to virtual versus in-person testing, especially with children and adolescents? We live in a COVID world now, so, clearly a lot of testing got translated onto a virtual platform, but is there a difference, and what are the differences, and how is testing impacted in a virtual world, specifically with the younger population?
That's a great question. And the fact of the matter is, just like every other segment of the mental health field, testing had to be converted to a virtual format by necessity. It was the only way to increase accessibility to testing in a world in which we couldn't sit in the same room. Now, so much of testing is sitting across from somebody, but the good news is, because so little of it has to do with my clinical impression and so much of it has to do with the validity and the reliability of the results, we're ultimately able to kind of make sure that psychometrically it was still intact. So voluminous research came out over the last 2 years to suggest that virtual testing and in-person testing is comparable in terms of the psychometric properties, which means it is still valid, it is still reliable. Now, there are certain diagnoses. It ultimately depends on the referral, which is to say, if we're sitting down with somebody who has behavioral issues, if we're sitting down with somebody who has social emotional behavioral issues, that's fine. If we're working with somebody who might be, potentially on an autism spectrum or someone with developmental issues, so much of it is being in the same room with somebody so you can assess their social pragmatics and see whether or not they're making appropriate eye contact. For just one example, it's difficult over Zoom to really truly get a sense of someone's, body language, their facial expressions to some extent. And their ability to understand even things like idiomatic speech or sense of humor, which is all very important behavioral observations in the assessment of a developmental disorder. So at the end of the day, testing holds up in a virtual world. And if anything, it provides a wonderful opportunity to increase accessibility, because so many people who don't live near major hubs, who don't live in the location of a neuropsychologist, can now get testing, regardless of how rural. That being said, with some diagnoses, it's still important to do in person.
I'd imagine too, with certain age groups, with the younger children, especially just sitting in front of a computer screen for a prolonged period of time without losing focus. I mean, I'm sure that's the case in person too, but I can imagine it's just different on a computer screen.
Very true, and it can be very much that way. And I think that the age of the demographic is going to be also an important consideration of whether or not you want to move forward. To be very honest, before I meet a patient, a lot of it has to do with deferring to the treatment team that knows the patient, or even deferring to the family. Some parents know for a fact that their child can't sit in front of a computer screen, and the reliability results are going to be, impaired. So I would never make any presuppositions about any specific client. What we want to do is we want to entrust the people who've known them for a decade, not somebody who's never met them yet. That being said, all neuropsychologists have a vested interest in the validity and reliability of results. So if there's any reason to believe that someone's not exerting appropriate effort, we will discontinue and reinitiate on another day. It doesn't do anyone any good to finish testing and ultimately give a report that says none of this data matters. Which is to say, one other comment about that would be, because we do live in a digital virtual age at this point, assessing someone's attentional capacities over something like Zoom can actually be really helpful, because it gives you a slice of life and it gives you a sample of data in terms of what they're actually capable of. So if they're still in virtual learning, it might be really useful to see how long they can attend. What is their sustained learning over time if they're going to be on a Zoom all day at school?
Yep. Yeah, it's a good point. We have a parent on here who's asking a question. They say that their son is about to undergo testing, and they were wondering, and specifically, he's having testing due to depression and anxiety, and suffers from memory loss from ECT. And this parent would like to know whether this type of a presentation would be good to share with their son before he gets the testing done, so that he knows what to expect and he knows what it's all about.
I mean, that's a question I would defer back to the parent. I mean, they would know their child more than anybody else. That being said, I think, like I said, I'm a dyed-in-the-wool believer in data and knowledge. So I think that it would be really helpful to know. If it were me, I would want to know as much about it as possible before I go into it, because it makes me feel more comfortable and more prepared, and then I'm not going to have as many confounding issues with like poignant anxiety.
Mm-hmm. Yeah, and I'll just piggyback on that too, David. I think from a treatment perspective, if somebody is already in treatment and we're suggesting testing for them, we definitely prep them for what to expect and what the testing is going to be like and how long it's going to be and what you're like, because it can be anxiety provoking and scary. And the more that we can prep them that they're going to not be there for just 45 minutes, it's going to take a long time. And I think they go in there and they feel a little bit more comfortable and more at ease, which is what we want.
Definitely. And again, I think that comes down to the collaborative nature of testing. When you refer someone in for testing, they should be working with the client, the family, the treatment team, the whole system. Because the fact of the matter is, when you meet somebody new, especially a young person, an adolescent, or someone in their emerging adulthood stage in their early 20s or late 20s, it would be really wonderful to be able to meet the neuropsychologist before you sit in the same room with them for 8 hours. right? It's important for them to be able to see you, to realize that it's not as, threatening as it may seem to some people, and to understand that we're not intending on putting them in a room with a Scantron for, all day. And that every question that gets asked is asked by another human being who is there to help.
Mhm. Another question came in regarding personality disorders. When personality disorders / features are diagnosed, how do you feel about disclosure, especially to vulnerable clients, i.e., especially with clients with a borderline personality disorder?
Well, that is a really, really great question. And the fact of the matter is, again, I would defer to collaboration. It's really important to work with the treatment team, because what we want to do is make sure that the information is productive. We want to make sure that they're actually going to take it in a way that's going to help them in their treatment. So in the event that somebody has something like BPD features, one feature of BPD is identity diffusion. And because of that, we can worry about people either over-identifying or under-identifying with the diagnosis itself, which is to say they could just refute it and dig their teeth in, and kind of like dig their heels in, and just, ignore and reject all of the test data as a result. Or on the controverse, they can over-identify with it and then start to adopt features associated with the disorder. So in those situations, I think it's really important in some situations to say diagnosis can be really, really helpful in helping you understand your experience. In other situations, I think it's really important to remind patients that they are more than any sort of category, right? That they're more than any diagnosis. That if I could diagnose if I didn't have to use the DSM, I would diagnose everybody with who they are, not otherwise specified, because everyone's a constellation of symptoms. And even if you look at the DSM, think about something like major depressive disorder. You have to meet 5 out of 9 criteria to meet the clinical threshold. If you do the iterations on that, that's like 300,000 different faces of major depression, right? So you can have despondent depression, irritable depression, apathetic depression, but people have, an a priori kind of preconceptualization of what depression looks like. So the issue is, when you give someone a diagnosis, they can Google it online, and then they start to read horror stories because those what's up there. What I like to remind people is that you're the same person before testing as after testing. Right? It doesn't change who you are as a person. You're struggling with the same things. You have the same strengths. You have the same weaknesses. And as a result, I think sometimes it's really important to hear the diagnosis if it's going to be productive. And other times people have to learn what their symptoms are that they're struggling with and treat it symptomatically.
Right. Yeah, no, David, we've certainly shared cases where with this particular diagnosis, where there's been times where we've collaborated and said, it will be so helpful for not only the client, but the family to understand that this is the diagnosis, and this is why, they're experiencing some of the feelings and emotions and interpersonal conflicts that they're experiencing. And then there's other times where we've said, and this person is so attached to this diagnosis, let's move them away from that and talk instead about, some of the features or the symptoms that we're seeing vis-a-vis the testing, rather than get them sort of more attached to this diagnosis. So it's like, it is so case by case. And yeah, we have to use the assessment as an intervention tool, basically.
Exactly. And I think assessment as intervention is really important in a lot of ways. And again, it's really important to remember that that's why feedback in assessment needs to be dynamic. When you get an assessment and it's a static document, a report, and a patient reads it, there's no contextualization for them. I mean, you can do the best to do it, but there's no follow-up questions, which is why when you have this conversation with somebody, even when you're delivering the diagnosis, because it really is helping make sense of their experience, you want to make sure that you're helping them understand what exactly about them is qualifying for this diagnosis, and how it's affecting their life, and how we can sow hope within the conversation to make them feel like this is not in any way a death sentence. It's more information, so they can take it from there.
Yeah. I often find it difficult to connect a patient with a provider that both does testing and also accepts insurance. Do you have any recommendation for those folks who could really benefit from testing but may not have the financial means?
So there's a number of testing clinics in the city. The issue is that there tends to be a long wait for those. I will say that testing is really useful, even if you have to wait for it. And I always recommend it, because I think, again, people change over time, but there are some things that we believe are static over a lifetime. So that being said, I would always recommend that any patient, that any family, call their insurance provider, get a list of in-network providers, and make those calls. Because the fact of the matter is, as a neuropsychologist, and I can feel comfortable speaking for all other neuropsychologists when I say we're here to alleviate a burden for a family, not create one. And we want to make sure that we make assessment as accessible and affordable as possible. So never be afraid to ask, where you can get discount testing if that's what you need to be able to get that information.
Thanks, David. Another question is coming in regarding assessment. Can you complete a neuropsych assessment if you are a licensed clinical psychologist with experience doing neuropsych assessment without completing a neuropsych residency?
So can you repeat the question? I apologize.
Can you complete a neuropsych assessment if you are a licensed clinical psychologist who has experience doing neuropsych assessments without having completed a neuropsych residency?
Okay, it's a great question. And while I will ultimately defer to the jurisprudence and the legislation in whatever district this licensed psychologist is credentialed, generally speaking, neuropsychological assessment is best done with a postdoc or a specific residency. That being said, like most other segments, it requires training, right? It requires supervision and consultation. So the fact of the matter is, you can do it. In fact, you can actually work as a psychometrist, which is somebody who administers tests under the supervision of a clinical neuropsychologist. And if you are a PhD level, through that training experience, you can also practice neuropsychology.
Okay. This is a good question. I get this question a lot from parents. What is the current consensus in the field about the use of stimulant medication in young adults on the day or days they participate in neuropsychological testing? I've worked with a number of psychologists, neuropsychologists who complete particular tests with clients both on and off of medication.
Yeah, and it's by design. So there's a number. It's difficult because I don't speak for the field of neuropsychology. I speak about what we do, but I will say, you're going to get a clinical picture one way or the other. So it's about what you need. So if you're trying to validate the diagnosis that they received previously, and that's why they're on the stimulants now, best to not take the stimulants because you want to get a clean sense of what their attentional capacity is. If you want to get a sense of what's going on for them now, if they have a standing medication that they take every day, and you want to see what they're capable of on a daily basis, what we'd consider to be functional capacity, you'd want to take the medication on the day of testing. Now, what we like to do is sometimes do pre-test and post-test. So we'll do a full evaluation. We'll pick one or the other to do the full evaluation. Imagine if someone has, like I said, a standing prescription for a psychostimulant, we'd have them take the stimulants. We can evaluate on a daily basis what they're capable of, and also evaluate, their social, emotional, behavioral functioning, personality functioning, and thought process on those days. And then we might have them come back on another day, not take it, and then redo a test of attention or memory and look at the discrepancy between those scores.
Thank you. You spoke a little bit about subjective tests and about self-report. Can clients, since it is self-report, manipulate the test?
That is a great question. Subjective tests ask questions in multiple ways, including like reverse coding to ensure consistency and provide for as much kind of retro and cross-validation as possible. And there are validity metrics built into the algorithms of the test. So we can see if someone is being highly guarded or defended, and whether or not they're faking bad or faking good. And while we don't do polygraph testing, and we can't ultimately kind of attest to the veracity of a patient's account, if one of the validity indicators is awry, in and of itself is clinically meaningful. Which is to say, we try to keep in mind that if a patient is reporting something out of line with the truth, it means that the patient either believes it to be true or wants the treatment team to believe it to be true. And either way, that's clinically meaningful. So that being said, because we marry kind of the three types of testing, the subjective with the objective and projective, and because the testing process is so long, manipulation is very difficult. So, in the sense that anyone can sustain a superficial affability, but faking bad, faking good, pretending to have ADHD, for example, or psychosis can be very difficult to do, if not impossible, after 6 or 7 hours.
You mentioned these words, validity and reliability. Even in that answer, you mentioned it throughout the presentation. I know this is a big question, but can you give us a brief explanation or talk a little bit more about what validity and what reliability means?
Yeah, absolutely. So validity is making sure that we're testing what we think we're testing, how accurate a test is. So if a depression test doesn't measure depression, it's invalid. And there's like several ways that we ensure validity, one of which is by determining kind of convergent and divergent validity. So convergent validity is when you have two questions that reveal the same result. And likewise, divergent validity is when two opposite questions produce opposite results, which is to say, two tests of depression should yield the same data, while a test of depression and a test of satisfaction with life should produce opposite data. So validity is accuracy, reliability be more like precision. Yeah, so reliability is making sure that the tests are producing the same data every time. So for example, for all intents and purposes, IQ is considered static over a lifetime. So the IQ you're born with is the IQ you die with. And as a result, the IQ test results for a specific patient should be the same, whether they're measured on a Monday or a Friday or a spring or a fall or this year or the next. And if the results of a test always come back different or have high variability, we would consider that to be unreliable. So validity and reliability are essentially psychometric properties that we need to ensure accurate data, if that makes sense.
Yes, thank you so much. All right, we are just about to start winding down now, but I wanted to again say thank you so much, David, for this presentation. And if anybody has follow-up questions, I know sometimes during a presentation, we don't think of all the questions that we want to ask. And then 10 minutes later, an hour later, we say we wish we would have ask something, but we forgot to. Please email us and we can certainly get the question to David and get an answer back to the person who has the question. Also, remember that we will be sending out slides and that this presentation will be on YouTube for people who want to revisit it. And we will be doing another roundtable next week, and we will be sending out invitations for that. For that roundtable, Dr. Carrie Wilkins from the Center for Motivation and Change will be with us, and she will be talking about their unique invitation to change approach, which is a compassionate model of helping young adults to seek the mental health treatment that they need. So we look forward to that as well. And we hope you all have a wonderful afternoon and evening. Thank you so much for coming.
Thank you for having me.